Assalamu alaikum wa rahmatullah. So we will continue for this lecture as we started in the past one. We started with the lower limb fracture and we started with the pelvis. In this one, we will go into the hip or the femur to start with. So injuries to the hip and femur. The hip joint, as you all know, is a ball and socket, as we already mentioned in the previous lecture. We have the femoral head and the acetabulum. It's a ball and socket. It gives you a wide range of motion. And so whenever you go up with the range of motion, the stability is going down. The joint is multi-axial. Ball and socket gives you abduction, adduction, flexion, extension, circumduction. So many movements. You all know that there is the labrum around the acetabulum, which make it more deep and preserve the negative pressure. So it's more hard to dislocate. And we have the extracapsular ligament, which is the iliofemoral, pubifemoral, and ischiofemoral. And the intracapsular ligament, we have a small depression in the head of femur. It's called the fovea, which is the place where the ligamentum teres is connected. These are the extracapsular ligament I told you about, the iliofemoral, pubifemoral, and ischiofemoral. Okay, this is posteriorly, this is anteriorly. I mentioned something called extracapsular and intracapsular. What is the capsule? So the capsule is the cover for the hip joint, because as you all know, inside the joint we have the fluids, which is the synovial fluid. The purpose for this synovial fluid is to ease the movement. So because it's fluids, there should be something to keep it inside. So it's the capsule. So two types of ligaments, intracapsular and extracapsular. So the articular surface of the hip joint, it's spherical, okay? And the acetabulum is lunate. So it's not fully covered with articular surface, the acetabulum, the part of the pelvis. So on the inferior part, there is something, a ligament. It's called the transverse acetabular ligament. So as you can see here in this picture, this is the lunate articular surface of the acetabulum. This is the transverse ligament. And on this side, you can see this is the fovea, the articular surface or the ligamentum teres is connected in here. There is a small little branch going through the ligamentum teres. It's called the obturator. It's called the acetabular branch of the obturator artery. It's not much blood supply to the head. In the pediatric age group, okay. In the adults, usually it's diminished. Ligaments, iliofemoral, pubifemoral, and ischiofemoral again. The femur. The femur is the longest and the heaviest bone in the body, as you all know. It articulates above with the acetabulum to make you the hip joint. Distally, it articulates with the tibia, yes, and the patella. So it makes you the knee. The upper end of the femur has the head, the neck, lesser and greater trochanter. I'm going to show you the femur. So this is the pelvis and this is the femur. This is the pelvis. This is the femur. So the femur is articulating with the pelvis and is doing all the moving. Abduction, adduction, flexion, extension, and circumduction. Okay? We're done with the pelvis. Now we're talking about the femur. In the femur, you can see the depression in here, which is the fovea. This is the head. This is the neck. This is the greater trochanter. This is the lesser trochanter. And this is the whole shaft going inferiorly to the femoral condyles. Okay? This is the lateral condyle, this is the medial condyle. And if you look at the condyles, you can see that the lateral condyle is higher than the medial. We will talk about it why. And posteriorly, you can see here the condyles and the intercondylar notch. Okay? Good. Again, anatomy of the femur. The head forms 2/3 of sphere, okay, which is a sphere. We have in the fovea ligamentum teres, and we have something called the femoral neck shaft angle. So if you look at the femur, you can see that there is an angle. The head and the neck is having an angle with the axis of the femur. Okay, so this angle is called femoral neck shaft angle. It is 125 plus minus 7 in adults. In the pediatric age group, it's much more. Usually in the pediatrics, it's 160. Then with the age, it starts to get less and less. So the greater and lesser trochanter, they are very strong because they have muscular attachment there. For example, if you look at this femur, you can know that on the greater trochanter, there are a group of muscles which are very, very, very important. It's connected here, which are the abductors. So when the abductors are attached here, they pull, abduction will happen to the hip joint. So the abductors, the gluteus medius and minimus, not the maximus. The maximus is an extender of the hip, so it do extension. So abductors on the greater trochanter. On the lesser trochanter, we have a long muscle is going down from the ilium. Okay, it's called iliopsoas muscle. Okay, so from the lower spine, from the ilium to the lesser trochanter, and it causes flexion. We have something called the linea aspera. Okay, it's where the muscles are attached. Very important. And the lower end of the femur has lateral and medial condyles, as I showed you. Okay, again, head, neck, trochanteric region, which is intertrochanteric region, greater and lesser trochanter, the shaft, and the supracondylar region or the condyles. Dislocation of the hip. Dislocation of the hip usually happens when there is a high energy trauma because it's stable, a lot of ligaments around. The labrum makes it very deep, so it's stable. The most common type is posterior dislocation because what's happened, the most common mechanism, it is called the dashboard injury. What's the dashboard injury? A driver is driving, he's having a flexed hip, flexed knee. So when trauma is coming, okay, so this is our patient, okay, he's having flexed hip like this. So when trauma is happening, it hits on the knee. So the knee, the force will be transmitted and posterior hip will dislocate. So the hip will dislocate posteriorly. The second one is the anterior dislocation, and we have central. So the mechanism, road traffic accident, high energy trauma. This is the dashboard injury. You can see here that the injury is coming to the knee. Posteriorly, it will dislocate the hip joint. Special features in diagnosis, the leg is short. It's not true short, it's apparent shortening, but it's short. Why? Because it's dislocated posteriorly. That's why it looks short. It's internally rotated and flexed. When you have a patient in the emergency room with a dislocated hip, forget about the dislocation, save his life. Again and again, ATLS protocol, A, B, C, D, E's. Then go and check for the hip dislocation. If it's dislocated, you have to do an X-ray. You have to make sure that there is no fractures in the acetabulum or in the head of femur. This is the position how the trauma patients come to the emergency room with posterior hip dislocation. X-ray. Sometimes you can see a fracture of the acetabulum or chip fracture. As you can see here, this is epiphyseal plate. So this is an X-ray for a pediatric. We have a classification of hip dislocation, which is Thompson and Epstein. So in type 1, it's dislocation with no more than minor chip. Type 2 is dislocation with single large fragment of the posterior wall of the acetabulum. 3 with comminution, fragment of the posterior wall. 4 dislocation and fracture through the acetabulum floor, which is the weight-bearing area from the acetabulum, the upper part of the acetabulum, this one that holds the weight of you. And finally, type 5 dislocation with fracture through the acetabular floor and femoral head. So whenever you go with the classification up, you can see that it's worse, and the prognosis is much, much, much worse. Another classification for the fractures of the femoral head only. Type 1, it's inferior to the fovea. So again and again, the fovea is the small depression in this femur. If the fracture is below it, in here, in this region, so this is type 1, okay? If it's above, it's type 2. Type 3, associated with femoral neck fractures. So it's head and neck. Type 4, which is associated with acetabulum fracture. So the more you go up with the classification, the worse it gets because it's more intra-articular, so you have to go and fix it, open reduction, internal fixation. And whenever I say intra-articular, now you know the rest that open reduction, internal fixation, anatomical reduction, absolute stability. So this is for the anterior, for the posterior, okay? what's the treatment? Every single joint which is dislocated, you have to reduce it, definitely. So reduction, reduction, reduction. Sometimes you have to rest the hip and put it on traction, sometimes for 3 weeks. The reduction should be under general anesthesia. Okay, you have to check for the neurovascular, you have to check for the sciatic nerve. It's very important. So how to reduce it under GA assistance of the pelvis. Okay, you have to steady the pelvis, flex the knee, and do pulling. So it's against the mechanism. Whenever the mechanism happens, you have to do against. You remember from Colles and Smith, when you have to do extension or flexion of the wrist. It's the same in here. So axial load, posterior dislocation, you have to pull it. Then you have to do CT. You have to do CT scan. It's very important. Complication, as I told you, sciatic nerve, 10 to 20%. Avascular necrosis, 10% of the cases, and in 40% if the reduction delayed. This gives you an hint that this is an emergency in orthopedics. So they always say, there is no emergency in orthopedics. No, we do have emergencies. So if you have a posterior hip dislocation, you have to reduce it as soon as possible. So you decrease the incidence of avascular necrosis of the head. If younger patient choices between femoral head replacement and hip arthrodesis, because if avascular necrosis happened, sometimes you will go like through a long way in the treatment. It's either small reduction technique, 2-3 weeks, everything's gonna be back to normal. The other way around, if the patient had avascular necrosis, which is a complication, you're gonna have a long journey with your patient. You may get realignment osteotomies. Sometimes you have to choose to do femoral head replacement, either total or partial. If he's more than 50 years, that's easier answer that you have to go for hip replacement. Why not to change hips for younger patient? Because they have limited lifetime to get or to use their prosthesis. After that, it will be worn up and you have to replace it again. So 5, 10, 15 years, you have to change it again. The patient is still young, a lot of morbidity, surgery, anesthesia, money, pain. So you have to think about it. Osteoarthritis, definitely. Whenever you have an intra-articular fracture, you have to think about osteoarthritis, as we already mentioned in the previous lectures. Now we're done with the posterior hip dislocation. Let's go to the anterior. It's much more rare. It's very rare. It's not as common as the posterior hip dislocation. So the leg externally rotated, adducted, and slightly flexed. In the posterior, it was internally rotated, as you remember, adducted. This is abducted and externally rotated. So it's the other way around. You have for sure to get an X-ray, you have to reduce it, and you have to make CT to make sure that there is no fractures. Be careful of the AVN again. That's why you have to follow up your patient. Finally, the central hip dislocation. Central hip dislocation, because the femoral head is inside the acetabulum, so the blow is pushing the head inside. So it will push inside and will get out from the acetabulum inside, which is called central hip dislocation. Central hip dislocation, why it is bad? Because it's an intra-articular fracture. It's pure intra-articular fracture, a complex fracture of the acetabulum. Many pieces, it's a puzzle inside the surgery. You have to replace each piece of this puzzle in the position so you get anatomical reduction and rigid fixation so you don't get osteoarthritis. This is an X-ray. This is very bad because you have here, this is the femoral head. You can see it's inside the pelvis now. It's fractured. It fractured the acetabulum. The head went inside, and unfortunately, that this patient had also a fracture of the neck. So imagine how complex this surgery is. Is the risk of avascular necrosis? Very high in this X-ray. So the fracture usually results from fall of direct trauma on the greater trochanter. In young adults, usually it's a high energy trauma because the acetabulum is really rigid. These patients often have multiple injuries. 20% of these patients, they might have fracture of the femoral shaft. That's a good percentage to memorize. 20% of these patients will have femoral shaft fractures. However, most common seen elderly post-operative patient. It's not very common to see a central hip dislocation in adults because it's very strong bone. More common in the elderly people because osteoporosis. This is an X-ray show you a femoral neck fracture. So this is femoral neck fracture. We're done with the central hip dislocation. Now we're in the femoral neck fracture. In young adults, it's not very common. It's more common in the elderly people. 20% is the percentage between the femoral neck fracture and the femoral shaft. This is the picture showing you a fracture in the region of the neck. And in the region of the neck, if we want to go in more details, we have like sub-classifications, let's call it. If it's just below the head at the articular surface, it's called subcapital, or transcervical, midway, or basocervical. So this is the base, transcervical, subcapital, basocervical, cervical, or basal, or sorry, subcapital. Very important. Because guys, it's very common to have a femoral neck fracture. It's very important to know the classification, okay, and the treatment. So the classification, we have one of the most common classifications for the femoral head fracture, femoral neck fractures, is Gardens classification. Gardens was looking for the stability actually for the femoral neck. So as you can see in type 1 in here, it's partial fracture. It's partial fracture. Type 2, it's complete, but it's not displaced. So type 1 and 2, they are realigned, no reduction needed, they are in position. Type 1 partial, type 2 complete. Type 3, unfortunately, now we have mild displacement, and type 4, oh my God, it's way more displaced. So 1, 2, 3, 4, the more you go up, the more it's worse, the more the risk of avascular necrosis, because the medial circumflex femoral artery and the retinacular arteries are getting more injured. Powell classification came and added a value to Gardens classification. So Powell's was saying that you have to know the line of the fracture, not only about the stability, sorry, about the displacement, you have to look for the angle. Why it's important? So basically when you are standing, okay, your weight is passing through a point on your body. It's called the center of gravity. What is the center of gravity? It is the point where you hold any object and it's in equilibrium. So if this femur, I want to know where is the center of gravity for this femur. So I will start to trying to have equilibrium in this femur. So I'm trying approximately like this. Okay, this is the center of gravity of the femur. So the center of gravity for the human being is just anterior to the sacral tube, just anterior to the S2. So the weight is going to the S2, then it is distributed to the femurs, then to the lower limb. So if you look at the force, where the force is coming to your femur, the force is in this direction, like this. It's coming from the pelvis, going directly to the femur, okay? So why Powell's is important? I know biomechanics now. Powell says, if the angle of the fracture is less than 30, so this is the horizontal line, this is the fracture line. So if the angle is less than 30, so this fracture will be better because it's having compression. So look at the weight is compressing this fracture. And do you remember Wolff's law? Where there is compression, there is bone healing. So we love compression. The problem is, Powell said, if the angle is from 30 to 50, when you are doing compression, there will be more something called shearing force, not compression, shearing. So because of shearing force, there will be more displacement with weight bearing. The fracture will be movement in macro motion, no bone healing. So if you look at the last one in here, you can see it's more than 50. So it's about like vertical. So when you have your patient standing, there will be shearing force on the fracture side, it will slip. So if in Powell's classification, type 1 less than 30, it's good because compression is going to happen. The more we go more and more with the angle, it's going to be shearing force, the fracture will slip. That means that your fracture is unstable. Okay, Gardens, stable, unstable. Powell, the fracture line with the horizontal. What's the angle? The more the angle, the more unstable fracture you have. Very important, because you need to plan your surgery. What implant I have to put for my patient? Is it screws? Is it dynamic hip screw? Or it is a nail? We will talk about them in a minute. So usually these patients with femoral hip fractures, they come with external rotation because of the short external rotators that are attached to the femur. So what are the short external rotators? There are 6 muscles: obturator internus externus, superior inferior gemellus, quadratus femoris, and piriformis. So these muscles are pushing or pulling the femur to external rotation. X-ray is very important. You have to get the displacement because higher rate of non-union and avascular necrosis. This is an X-ray showing a fully displaced neck of femur fracture, which is Gardin type 4. And you have to calculate the angle in Powell's classification, which is, I think, more than 50. So it's type 4 Gardens, type 3 Powell's, which is the worst. Treatment: non-displaced fracture, okay? Displaced fracture, both of them in the femoral neck, they have to be fixed because it's a weight-bearing bone and we have to return the patient to his function as soon as possible. So usually it's operative treatment. Usually it's operative treatment. It's very, 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 very rare that you treat conservatively. If your patient is multi-trauma patient, he's unstable, you cannot operate on him now, you can wait. On the other hand, you have to fix. You have to fix. Reduction, fixation, and early activity. Okay, so early activity, so you have to prevent thromboembolism. It's very common to have DVTs, thromboembolism, and fractures of the pelvis and the hip. So you have to give anticoagulants. Treatment: what if you cannot really reduce the fracture? Whenever it's hard, just go and reduce. Open in young, open reduction. In adults, you can go for hip arthroplasty, either bipolar or total hip, depends on the surgeon and the patient. If it's undisplaced, sometimes in pediatrics, you can go and put hip spica. What's hip spica? It's a POP for the lower limb. We will talk about it in DDH lecture. If it's displaced, you can go and fix it with either wires or screws. You can put screws for the hip and fix it in position. The wire is temporary until you put your screws, then you remove it. Complications: high incidence for complications. Bed sores, pneumonia, thromboembolism, fat embolism, so whatever, a lot of complications, infections, avascular necrosis, non-union. So it's very important to reduce the fracture as soon as possible and to fix it. Fractures of the femoral neck, treatment for non-union, it depends on age. So if you have non-union, what to do? If he's less than 50, either you put bone graft, you are trying to preserve the head. You are trying to preserve the head because if you have a dead head in a young patient, this is very bad, very bad. It's going to do osteoarthritis. If you put a total hip for this patient, the outcome is okay, is good, but the problem with the age that he's young and you have to do another prosthetic or you have to change this prosthesis sooner or later. If he's more than 50, so you can go and do hip arthroplasty. Okay, we're done with the neck. Now let's go to the intertrochanteric fracture. So what are the intertrochanteric fracture? Again, this is the femur, head, neck, trochanteric region. So the greater, lesser trochanter. The area in here, it's called the trochanteric region. This is one of the most common fractures for the old people, for the elderly people, because of osteoporosis. Usually the known history that's coming to the emergency room that he's standing or walking, or she was standing or walking and fell down, direct trauma on the hip joint, like falling down from standing height. Low energy, abnormal bone, pathological fracture because of osteoporosis. So usually it's extracapsular, outside the capsule, okay? Shortening external rotation on X-ray, you can see the fracture, which is the line between the greater and lesser trochanter. As you can see here in this X-ray, this is a comminuted line between the greater and lesser trochanter. So there is a classification. Yes, I'm sorry, orthopedics have a lot of a classification. We have Kyle classification. Type 1 is non-displaced, only a crack, which is non-displaced. Type 2, this minimal displacement with comminution in the lesser trochanter. Type 3, comminution, you have greater trochanter piece, lesser trochanter piece. Type 4, severely comminuted. The more you go up with the classification, the worse it is, as we all know. The problem is we have a fracture which is called a reverse oblique fracture. Reverse oblique fracture, which is this line. Why it's reverse oblique? Usually the greater trochanter fracture are like this, okay? The reverse oblique, it's the other way around. Is it worse or better, and why? So the answer is, if we go back, as you remember, I told you in the biomechanics, when the human being is walking, there is force coming through the head to the neck, like this. So it's compressing the fracture on this line. It's compressing the fracture here. It's compressing the fracture here. The problem with the short oblique fracture, that it's the line here is with the weight. So the weight is going like this, from the head to the neck to the trochanteric region, and the fracture line is parallel with the weight. What's going to be happening? Shearing force again. Shearing force. Shearing force means unstable fracture. Let's go back a bit here. So what should we do for these patients? Usually it's operative. We have to operate. So what's the options for the operation? We have something called DHS and we have a nail. So what is DHS? Dynamic hip screw. Dynamic hip screw. It's a screw. We put it inside the neck, okay, to the head, and we have a small plate on the femur in here. So let's try drawing to make your life easy. Okay, I'm gonna try the drawing tool. Okay, let's draw. So, okay, perfect, it's drawing. So the DHS, what's happening, that you have a screw in here that goes in. So this is the screw. I'm sorry about my bad painting. And there is a plate on the lateral aspect of the femur. This is the plate, okay? And it has here holes. These holes, we put screws in. Good. So the idea of the DHS, that when the patient is walking, there will be weight, right? So the weight is gonna press on this part. The nice thing in the DHS, the dynamic hip screw. Why it's dynamic? Because when there is compression on it, this screw is going through something called here the barrel, okay? So the screw is going inside the barrel with the compression going inside and return to its normal position. So when the patient is walking, more compression is happening, more compression. So we love compression orthopedics. That's why DHS is very good for these patients. But on the other hand, if we go to this patient, let's put a DHS in here. So the DHS, this is the weight again. Let's go for here, let's draw. Okay, so if we put here the screw, this is the screw, and this is the plate. What's gonna happen if the patient walk on this fracture? The force will be like this, and there will be shearing force on the fracture. The metal will fail. You will have a break in the DHS, the dynamic hip screw, because there is no compression in the bone, there is shearing, and it will slip. That's why it's contraindicated to put DHS, dynamic hip screw, to reverse oblique fracture. So what's the solution? Nail. We put intramedullary nail, which is like this, nail inside and a blade inside. I will show you in a bit some few pictures. Okay, I hope you understand the idea. So treatment, we already talked about treatment. You have to go for surgical complications, thromboembolism, pneumonia, bed sores, failure of fixation, malunion. So we're done with the intertrochanteric. So we're done with the head, neck, trochanteric region. Let's go for the subtrochanteric region, which is the area below the lesser trochanter, okay? Usually in the young adults, it needs high energy trauma. In the elderly people, it's much easier to get broken. The leg also is externally rotated, but the proximal part, this part, sometimes it's externally rotated and flexed. Why? Because the iliopsoas, which is holding the lesser trochanter, is holding this part and flex it, external rotated. So treatment, open reduction, internal fixation, nail, plate. We're done. Femoral shaft fractures. Femoral shaft fracture is like any diaphyseal fracture. You need Length, alignment, and rotation. Restore length, alignment, and rotation. So is it intra or extra-articular? Extra-articular. So the anatomical reduction? No. You need functional reduction and absolute stability? No. You need relative stability. So in young adults, it's need high energy trauma. Usually if it's transverse, it's high energy trauma to the soft tissue. So you have to think about compartment syndrome and bleeding inside the femoral compartment. This is a transverse fracture, and this is an external fixator, or it is a traction, skeletal traction. So we have two types of traction, either skin, we put on the skin like rubbers, or bandage and we put traction. The problem, it cannot accommodate much weight. Skeletal, it can accommodate more weight. That's why, and when it's femur and a lot of muscles outside, you know, the anterior, posterior compartment and medial, you have a lot of muscles. They are like tough. That's why we have to put sometimes skeletal traction. This is a very nice classification, okay? So this is Winquist classification. It's type 1 if it's a small, tiny fragment in the cortical part. Type 2, as you can see, there is more than 50% of the cortex contact. Here, less than 50%, type 3, type 4, segmental or comminuted fracture. There is no contact with the proximal and the distal part. Very important. Treatment, it's either immediately, if you have multi-trauma patient, it's not the time for surgery. You can put your patient on traction until he's stabilized. If your patient is stable, you can go and fix him immediately. So, this is a nice picture showing an intramedullary nail. So this is the nail I told you about. This is the nail I told you about. These are two screws fixing the neck. So you can use this nail to fix the femoral head fractures, the femoral neck fractures, this intertrochanteric region, the subtrochanteric region, and the femoral shaft. So a lot of uses. But in the intertrochanteric region, you can put either DHS or nail. But if it's reverse oblique, shearing force again, no bone healing, so you have to go for nail. If it's open fracture, you have to treat it as open fracture for sure. Antibiotics, anti-tetanus, debridement, make sure there is no neurovascular injury. Sometimes you have to put external fixator until the wound is clean, then you go and fix. Don't put metal inside a dirty wound because it's a source of infection. Complications, vascular injury, DVTs, infections, delayed union or non-union, malunion, and another complications like fat embolism, ARDS, blood shock, and so on. Finally, in this lecture, we will talk about supracondylar fractures of the femur. And you can see from the picture that they are important because of the neurovascular injury, which is the popliteal artery mainly. So in young people, high energy trauma, and elderly people, osteoporosis as in all, the knee is swollen and deformed. You have to check for tibial pulses for sure. Distal pulses are very important, posterior tibial and dorsalis pedis. On the X-ray, you have to know the classification. It's either extra-articular or intra-articular. If it's extra-articular, we need functional reduction and relative stability. If it's intra-articular, you have to know what type of intra-articular fracture. It is one condyle or two condyles, unicondylar or bicondylar. And that's why you have to know the implants that you will use. If it's intra-articular, you need rigid fixation. So you need screws and plates. So type A, B, and C. This is an X-ray showing a supracondylar fracture on the AP and the lateral. Treatment, you can put your patient on traction, make sure of compartment syndrome. If your patient allow, you can go and fix him. You can use plates, intramedullary nails if it's not too low the fracture, and screws. The problem is because if it's intra-articular, you can end up with osteoarthritis, joint stiffness, and non-union. I hope it was a very useful lecture. And the next lecture, we will continue about the lower limb, part 3. Thank you very much.